to hand the controls over to you so we can go ahead and get up your first slide. That way we can go ahead and have it up and ready to go. Perfect. You're a pro at this.
Yeah. You're supposed to say that at the end.
All right. Everyone, thanks for joining. We've got a big group today. It's about 4 minutes till. We're going to start right at the top of the hour. So again, thanks for joining. We'll get started here in just a few minutes. I'll do the introduction, and then we'll go from there. So again, thanks for joining. All right, Kim, we're getting close. For those of you who just joined, thanks for joining us today. We'll get started here in about 1 more minute because we've got a packed hour-long presentation. Again, thanks for joining. We'll get started here in just about 30 more seconds. All right, we'll go ahead and get started. Again, thank you so much, everyone, for joining us today. This is a big webinar. Today's title webinar is called Tracheostomy Hospital to Home. And at this time, I would like to do an introduction to our speaker. So today, we have the pleasure of having Kimberly Wiles, who is currently the VP of Respiratory Services at Allegheny Network Home Medical Equipment in Pittsburgh, Pennsylvania. She was the AARC Home Section Chair for about 3 years, 2013 to 2016, and served on the AARC Board of Directors. She co-authored the 3rd edition of the AARC's A Patient's Guide to Aerosol Drug Delivery in 2017, and she's also presented many and numerous respiratory conferences. So with that, Kimberly, we do really appreciate your time today. We've done a lot for this webinar, so I know it'll be great. So again, thanks, Kim, for doing this, and I'm going to go ahead and hand it over to you.
Okay, thank you so much, Kristen. Well, good afternoon, everybody. So we are going to spend the next hour talking about tracheostomy and really talking about how we can effectively transition our patients from hospital to home. But before we do that, we'll talk about some indications and complications of tracheostomies. We'll look at some different features of the various tracheostomy tubes. Then we'll start to discuss how the discharge plan of the tracheostomy patient can be enhanced to optimize care, and identify differences and limitations in providing care for the tracheostomy patient. So let's start with an overview. So some of the definitions that I'm sure we're all used to hearing, but we'll just do some definitions to clarify. So the tracheotomy is a surgical procedure to make an opening in the trachea, done under general anesthesia. and typically between the second and third tracheal ring. And then the faceplate is sutured to the skin. The tracheostomy is the actual artificial opening into the trachea. So I'm sure nothing new for all of you out there, but just wanted to clarify some of those definitions. So a tracheostomy actually provides an air passage to help in breathing when the usual route of breathing is obstructed or impaired. So we're bypassing the whole upper airway, which is responsible for adding the heat and humidity to the air we breathe. And whenever we do bypass the upper airway, we know that that can end up into some complications later on, and we will talk about that. And then if we don't adequately maintain the upper air of the airway, it could result in airway obstruction, respiratory distress, pneumonia, so readmission, and actually potentially death if not maintained properly. So some of the indications for tracheostomy would be a prolonged intubation to facilitate ventilation support and weaning, pulmonary hygiene, patients that are unable to clear their airways, upper airway obstruction such as OSA, and I don't think we see this quite as much as we used to many years ago for those of us who've been in home care for quite a while, but if there's any other type of obstruction in the upper airway, maybe caused by a mass or an inoperable mass, then you may need a tracheostomy. The inability to intubate, head or neck surgery, trauma, airway protection, so any kind of neurological diseases or traumatic brain injury. So these are only a few of the indications, but anything that really obstructs that upper airway. And I always like to use an example of we had a gentleman that worked for us, and I was doing training with the staff on tracheostomies, and he's 20 years old, and he spoke up and said, I had a tracheostomy. I'm like, really? You're a healthy individual. He had a abscess tooth that swelled enough that caused his upper airway to occlude, and they had to insert a tracheostomy. So there's multiple reasons. This just kind of touches a few of the indications. So when we do the tracheostomy, there are physiological changes that patients have to deal with. So there is a decrease in airway resistance. There is loss of the normal humidification, heating, and filtering process. So whenever we breathe in the air, we typically will heat and humidify it by the time it gets into the lower airway. When we put a trach into a patient, we completely bypass that process. So we have to make sure that we appropriately humidify the air that they breathe, and we'll talk about that later as well. There's also a decrease in the smell due to lack of the stimulation of the olfactory nerve. There's weakened cough due to inability to maximize the thoracic pressure. As we know, there's also altered speech, and there's altered swallowing as well. So there's many physiological changes that occur with a tracheostomy. We also have to worry about complications because we know it's an invasive procedure. So with that comes, risks, early and late complications. One of the early complications would be apnea. And this is really more common in children because we lose that anatomic dead space and there's a decrease in the respiratory drive. We could also see an air leak, so a small pneumothorax, which potentially are usually self-resolving, accidental decannulation of these patients. And at this point, if they decannulate early on, the tract is not formed, so we have to be very careful with these patients that that tube is secured. There also could be airway obstruction. Most common is dried blood or mucus. So again, extremely important to maintain that airway and keep it clear and free of these blood and mucus. Hemorrhage, possibility for a hemorrhage, and it's also a possibility of damage to the larynx. Some of the later complications would be accidental decannulation again, but typically as patients go further in their disease state, that tracheostomy tract will mature and make insertion easier. But we still have to make sure that tube is properly secured to minimize that risk. Airway obstruction, again, could still be a late complication if a patient has a lot of secretions and we are not humidifying them properly. Again, a mucus plug causing that tube to block off. Hemorrhage, the innominate artery lies anterior to the trachea, and although this is rare, it does happen. I've seen it happen twice in my career. So we have to be very careful that that trachea is secured. And of course, infection, tracheal stenosis due to the blood flow occlusion. And that's usually caused by the cuff tubes, or again, we could still have that patient that tube is not properly secured. And then a granuloma formation. If it's, again, I keep saying if it's not well secured, as you can see, it is so important to make sure these tracheostomy tubes are in place and secured. Whoops. So some of the high-risk groups that we look at whenever we're talking tracheostomy is, of course, children, smokers, diabetics, alcohol abusers, any disease immunocompromised, any chronic diseases, really any comorbidities that may exist with this population whenever the tracheostomy is performed. So let's talk about some tracheostomy tubes. So we have different materials in tracheostomy tubes. We have the PVC, or the polyvinyl chloride, which is a flexible tube. It's typically your most common. It softens at body temperature. Silicone is flexible. It's just naturally soft and conforms to the airway. And then you do occasionally see the metal ones, which are very rigid and extremely expensive, and they usually don't have a cuff involved. So when we look at tracheostomy tubes, we can actually divide them into different categories. The first being the single cannula, which is just an outer cannula with your flange or your faceplate and then your adapter. The dual lumen cannula is actually your outer cannula with your inner cannula in place. The inner cannula can be disposable or non-disposable, and we will talk about that later as well. And then we also see fenestrated tubes in the home, especially because once they get to the home, they've been used for weaning, and they also allow patients the ability to speak. It allows the airflow to flow up past, out these holes and up past the larynx. Other tube features are cuffs. The purpose of this is to seal the airway. Stable patients typically have deflated cuffs or they're cuffless. In home care, we typically see the patients who have been weaned or are stable come into the home and do not have the cuff inflated, or they have been transitioned to a fenestrated or a cuffless tube. Stable patients, again, in the hospital, you're going to see most patients with a cuff and inflated. But when you look at the different types of cuffs, you have the foam cuff, which the pilot balloon is open and allows higher pressure in the trachea to displace air into the atmosphere. So it is really potential for less damage to the tracheal wall because it changes, okay? And then you have the air-filled cuff. And this is one that you most likely will see in the hospitals, and we still see them at home too. And you have to really make sure that these are not overinflated, because if they're overinflated, they will cause tracheal damage, tracheal wall damage. And then you have cuffless, and you'll see the cuffless a lot of times in the pediatric population, but you will see it also in home care whenever they go home and transition. So cuff management in the home is a lot different than cuff management in the hospital. In the hospital, you usually are pretty prone to checking the pressures. So you will usually see 20 to 30 centimeters of pressure will minimize that risk to the tracheal wall. In the home, we don't typically monitor the cuffs. Again, as I said, they're usually cuffless, and we don't really monitor the pressures. But cuffs are utilized for patients on mechanical ventilation, and if we need to decrease the risk of aspiration, then we will figure out the exact amount of airflow that needs inserted into this, but again, not routinely checked with the manometers. So understanding trach size, and I'm sure there's a lot of you out there can appreciate this and can understand this, but on a Thursday afternoon at 4 o'clock or a Friday afternoon at 5 o'clock, you get an order for a trach being discharged, trach patient. And they say, well, it's a size 8 trach. and you're scrambling to try to figure out, okay, well, what size of it, what 8 trach, what's the model, what's the sizing combination, because we can't just go with what the number is on the trach. And we see it all the time. And again, then we're scrambling to try to figure out, what does this patient need? So it is so important to have the full sizing, letter, number combinations, of course, as well as the manufacturer, because they're all different. If there's special sizes involved, we need to know what that additional information we need. So for example, you do see extra long trachs. We need distal length, proximal length, and radial length. So we need all of this information in order to process this order and get this patient transitioned into the home safely and effectively. If you see a D in the letter number combination, that usually denotes that the inner cannula is disposable. Now, not always, but most likely if it says 8 or 6D FEN or 8D FEN, that usually means that it will accept a disposable inner cannula. Okay? So it is imperative that the proper sizing is communicated to the home care provider. Sometimes that can be a challenge. So this is just a little chart to show you how these trachs vary by manufacturers and brands. So for example, if you look at this example, a Portex in a size 6, if they called in and said, okay, we have a size 6 trach, and if we don't know the manufacturer, we could put a Bavona, we could do a Shiley, and you can see they all have different outer diameters and lengths. So that's why it is so important to make sure we also know the manufacturer. And when you get into some of these larger hospital systems, they may have multiple manufacturers that they're using and not just one typical brand. So this is just a slide to really show you how we can see the differences in the boxes and the trachs themselves. And when I do some of my training with the home health agencies, you know, some of them are surprised because they get into the home and they have none of these boxes. But that's why when we talk about a safe transition, we really want to see is, can the hospital send this information home, send the whole box. So for example, here's one that shows it's a 4 FEN. Here we have a pediatric that shows it's cuffless, and here's the actual item number. And when all else fails, you can go to the neck plate, which will actually give you all of the information on it. Now, there are rare instances where the patient may be coming home from a skilled nursing facility and they've had the same trach for quite a long time. Sometimes in those particular cases, it is something that you need to stress with the facility, that the physician may need to change that trach prior to them coming home if they really don't know what size that trach is. So the big part of this webinar today is really talking about how do we safely and effectively transition these patients to the home. We are all looking at transition of care in multiple disease states, and sometimes tracheostomy gets, I think, pushed to the back burner sometimes because we're so focused on COPD and other disease states that we forget that it is so important for these patients because they are critical patients going into the home. And for those of us on the call that work in home care, we know, and if you've been in home care for a long period of time, you have seen the transition from in the early days of home care to now we're seeing much sicker patients in the home. And the hospitals are much quicker, and the skilled nursing facilities much quicker to get them out of their facilities and into their home. So the first thing we really need to understand is, what does the home environment look like? Well, we all know that it's a very uncontrolled environment, and we need to understand what that environment looks like. If the patient's coming home on a ventilator, that's easy because we all do a home assessment prior to setting the ventilator up, so we know what is in that environment. An uncontrolled environment can really add new obstacles to patients. And if we don't know what we're dealing with when we get the patient into the home, we could run into problems later on. There's no standards of care. Once the patients get into the home, there really isn't a standard of care or best practice. We can read a lot of articles that give us best practice and talk about best practice, but there's really nothing documented. Even if you go to the AERC, the clinical practice guidelines, there really isn't anything for tracheostomy care or trach care or transitioning the trach patient into the home. So, we're kind of all out there floundering to figure, what is the best practice in caring for these patients. Lack of ownership. I find this extremely frustrating, and I'm sure everybody out there does, is sometimes when they get into the home and we run into problems, we have no one that can really take ownership of that patient. So there may be a PCP involved, there may be a pulmonologist involved, a surgeon involved, whoever. We've got to figure out who is going to own that patient. When there are obstacles and there are problems, we really need to be able to get to that person to really talk about this care. And then continuity. So we really want to be with our patients. We want continuity of care. So we want that continuity of care to start within the hospital and carry out through the home. And we all know sometimes that's a little bit difficult, but we really need to push this with our facilities and educate them. And I know that everybody's out there probably thinking, yeah, easier said than done. And I completely agree, but we can't give up. We have to, I think we've made great strides, but I think we have to continue to work with our partners and really work, because the main focus is the patient and making sure they're transitioning safely. So how do we prepare for discharge? We need education prior to discharge. I can't stress that enough. These patients, when they come into the home, they may not have been trained on trach care or suctioning. And as HME providers, we typically aren't giving that education to the home. We're there to support that patient as far as the equipment and the supplies and initial training, but not really to support them and do trach care and do suctioning in the home. So this is really, we have to teach self-management for these patients. And if they are unable to self-manage or have a caregiver to manage these patients, we really need to know that prior to discharge. So that education has to be started early on in the process. And we are seeing across the country in many states where they are putting respiratory therapists in as case managers and working the discharge process. So I think we're getting there. It's just going to take some time. I think where we have a need probably is in some of our skilled nursing facilities. I think, because we don't have a lot of resources as far as respiratory therapists in those facilities, and sometimes those transitions can be a little bit more difficult to handle. The other thing is we have to make sure there's communication to the HME provider as well as the home health agency. So we can't just accept a patient at 3 o'clock or 4 o'clock on a Friday afternoon without any particular communication to the HME. And this is something that I have really tried stressing in many of my lectures that I've given over the years, is the HME provider is rarely involved in the discharge process as far as communication. So in other words, when we're in the hospital and a patient changes sites from the emergency room to the intensive care unit to the general floor, there's always a report given. Well, when we get into the home, when the patient leaves the hospital and goes into the home, the most we get usually is what the orders are. So we really need to start bridging that gap and working with the acute care facilities and the subacute care facilities to really bridge that communication gap and get the HME provider within that those meetings and all that preparation. Some of the things that is so important, and we all know this, is not all of us carry every size, brand, manufacturer of tracheostomy tubes out there. So in order to effectively transition, we need a heads up, basically, so we know to get the equipment in and the supplies in if we need to. And then again, the resources. Is there caregiver support? Do these patients really understand what they're going to be dealing with when they get home? Do their caregivers understand how much support they need? And also, if that isn't given to the patient and the caregiver early on in the discharge process, then we run into complications once they get into the home. So if we could standardize the discharge process, that would actually be our ideal scenario, because we could identify and eliminate some potential barriers. You know, we have to know the patient is medically stable. The last thing we want is a patient being discharged and the patient going directly back to the hospital. And we just had this not too long ago, and it was in one of our skilled nursing facilities. The patient was not medically stable. They discharged him into the home, and the family and caregiver really had no idea what they were getting themselves into. And when we showed up with all the equipment and the respiratory therapist, they told us, nope, you guys can go, and we are going back to we're going to go to the emergency room, because no one explained it to them. So again, it goes back to, we could have eliminated those barriers if we did a little bit better training on the front end. And again, that is something that is not always available to us, but we really need, as respiratory therapists and care providers, we need to start working and continue to work with our facilities to build that. And again, the caregivers demonstrate, you know, their willingness to care for the patient and understand what is involved. And I already talked about this as well, is the HME company really needs to be notified early in the discharge process so that we make sure that we have the supplies and the equipment needed for this discharge. And especially if it's a ventilated patient. And I think probably, and I'm going to say this in a general format, but I think in most part, when patients are going home on an invasive ventilator into the home, I think we're giving a good bit of heads up. I'm hoping that. I'm sure maybe there's somebody on the call that can contradict that, but we do typically go in and look at the environment and see if it's a safe environment for that patient to come home in. Now, if it's just a trach and there's no ventilator involved, more than likely we're not doing a home assessment prior to that patient going in. But, you know, those are questions that on the front end, care management and the discharge team really can get that information from the patient and the caregivers to make sure there's no problems once we get there. So we like to use discharge checklists. So we have checklists for our facilities and our transition of care coordinators, and this really is within the hospitals, and we're trying to incorporate them into some of the nursing homes as well. But if you have checklists, it really eliminates some of the errors or some of the misses that you may have in discharging. So the number one thing is, if it's a new trach patient, they need to have a home health agency ordered. We all know we are strapped as HME providers, and we cannot provide respiratory therapy services in the home and be there on a regular basis. So a home health agency needs to be ordered so that they can go in on a regular basis, work with the patient, work with them on trach care, suctioning, and really as a team approach to that transition. We also need a discharge packet that includes our demographics, our health, our history and physical, medication profiles, so we really know what type of patient we're getting into the home, what are the specific orders, and were there any risks identified by care management. Then the HME contacted, and was the equipment order placed in advance? So again, there are different things that the HME provider has to know prior to accepting that patient. And, you know, I think I use this oxygen order as a good example because, and I wish I could get a hand out there, but you guys can stick up your hand, I just can't see it. But how many times have you gotten an order for a trach patient at 3 liters per minute of oxygen, or 8 liters per minute of oxygen, because they just looked at what the nebulizer was run at? Well, we all know we have to adapt once they get into the home, and we're going to talk a little bit more about this later in the presentation. But typically, we can really max out at 45% oxygen, and we can go a little higher depending, but most of the time you're getting into those higher percentages in the home. Now we're maxing out on our peak inspiratory flow rates, and we may not be meeting the needs of those patients. And do the patients need high volume humidity? So, you know, we, a lot of times, again, we'll just get an order for 3 liters per minute trach patient, and now we have to make sure we call back and say, do we want humidification? Do we, you know, what all do we need with this order? So if those things are taken care of in advance, in conjunction with the respiratory care department, then we can eliminate a lot of these errors. And then the suction machine. We've gotten a lot of orders where they don't even order a suction machine when they come out. So if we, again, if we have the checklist, then we know we're going to eliminate those errors. And again, what kind of supplies do they need? What size trachs? What supplies? Is there, again, the home health providing any of this stuff? So we really need to know all of this information. Again, the tracheostomy tube. So what is the brand? What is the accurate size? What's the frequency of change? We very rarely in our area get change orders for tracheostomies. So they do go back into the physician's office for these or back to the facilities, and sometimes they just don't get changed, and we're going to talk about that further on as well. But again, I can't stress enough that if you're having difficulties getting the appropriate orders out of your facilities, develop a checklist for them, because that will really help when they're preparing the order. So we all know that we're accepting these patients, but we really need to decrease the anxiety of the patient and the caregiver, and we can do that by the checklist and also by bridging the supply gap. So when patients go home, we need to know they have some basic supplies prior to them going home. And we all know that extra supplies sit in their rooms. They have an extra size, a smaller size trach usually. There's usually an extra tracheostomy tube. We need to make, as the part of that discharge process, that all of these items go with them. So if there's any extra parts in the box, including the box, don't throw the box away. We want that to come with us so that we know what the patient needs. Disposable inner cannulas. Many of these patients will come home where they've inserted a tracheostomy that will accept the disposable inner cannulas because it's easier for trach care. So we need to make sure the patient has a couple of those in case of an emergency. Suction catheters, tracheostomy care kits, tracheostomy tube holders, gloves, and we're not asking for patients to come out with a week's supply. We're just saying a couple days. And the reason why is if a home health agency is involved, depending on their insurance, the home health agency is responsible for providing a lot of these supplies. And a home health agency has 24 to 48 hours to open a case. So the patient may go 24 hours prior to a nurse coming in. And the nurse at that point may only have a few supplies at that time to give them. She has to order them. So we just want to make sure we can decrease that anxiety before the patient even goes home. So they know they have some extras before the nursing agency or the home medical equipment company arrives. So now we're going to talk a little bit about maintaining the tracheostomy. And I know as HME providers, a lot of times we don't provide or do this service, but it's important for us to have a refresher course, I think, at times, because patients will ask questions and they will want to know, and we need to be knowledgeable so that we can help them, again, to keep them home and to keep them in their environment. So when patients are in the home and they need suctioned, it is really, how do they know they need suction? Usually the patient requests it, they know. Or if a caregiver is caring for somebody who is not able to respond, then it's usually noisy, moist-sounding respirations. They'll see an increase in pulse rate or just labored respirations, may hear some wheezing. A lot of these patients, family members we all know, go out and buy pulse oxes for everybody out there anymore, the little finger ones, and they'll put it on and they may see that the saturation is low, and that would be an indication for suctioning as well. So we also want to train our patients that we don't want to over-suction as well, because if you over-suction, you're blocking the airway, which can cause your decrease in oxygen levels, could cause respiratory failure, readmission, pneumonia. So we really need to make sure that we're suctioning appropriately. Well, when we get to the home, there's a little bit difference in the suctioning. We do clean technique versus sterile technique. So the patients are not given sterile suction catheters and gloves. They can clean them and reuse them. It all depends on their payer. The payer really has determined, in most cases, how many supplies these patients get. So if they're suctioning, maybe they get 30 suction catheters a month. If they're suctioning 2 and 3 times a day, they can clean and reuse those suction catheters. So again, we're not using, they may open up sterile initially, but they can reuse them in the home. The equipment, we give continuous suction. Highly recommend best practice of giving them a portable that does have an internal battery so that in the event of a power failure, they do have means of clearing that airway. And then the disposable. So we really need to know what catheter size. The DME should know that from what they've been using in the hospital. Again, we don't use sterile gloves. We use non-sterile, and suction kits that have your little container and your gloves and your catheter all in one little kit are typically not reimbursed in the home. I know in the Pittsburgh region, which is where I'm located, this is typically not covered service. So as far as cleaning procedure, all they need to do is make sure they're washing and flushing them after they use them, and then they can wash and flush in a hot soapy water and then disinfect in a water vinegar solution or commercial disinfectant. And the water vinegar solution, and here's where we go to, there's no standards of care out there. When I was getting ready for this presentation, you can find anything from a 1-to-1 ratio, a 1-to-3 ratio, not using white vinegar at all, to a commercial disinfectant. So I pretty much, I know what we use here is usually a 1-to-3. So, you know, that's really, as long as they're cleaning them and using something, I think at that point we're okay. It's those patients that aren't cleaning them appropriately. And make sure they're rinsed inside and out, and then air dry. Tracheostomy care, this really varies with each patient, and it depends on how old the trach is. It depends on how much mucus they may have or secretions. So obviously with increase in secretions, we have an increase in frequency of trach care. So what are the supplies that the trach care comes with, you need for trach care? You need a trach care kit, peroxide and water, and this again goes back to what are your combinations. Is it 1-to-1? Is it 1-to-3? We don't know. There's really no best practice. Again, when I was doing research for this, it was all over the place. So one would say 1-to-1, one would say 1-to-3. So I think as long as you're using some mixture of that, I think we're okay. So disposable inner cannulas if applicable. So if the tracheostomy tube can accept disposable inner cannulas, then usually they're changed every once or twice a day. But what we have to make sure we stress to our patients is they should not be cleaning the disposable inner cannulas. If you read the manufacturer's insert, it will tell you that the material may decay or I can't think of my word. But we want to make sure that they're not cleaning those disposable inner cannulas. And then, of course, the trach tube holders, and we're going to talk a little bit more about that in a minute. So what technique do we use? Well, they remove the inner cannula if it's applicable. They clean the inner cannula with a mixture of the peroxide and water, rinse very well. And again, disposable inner cannulas do not get cleaned. The stoma should be cleaned with a peroxide mixture and then rinse well. Use the pipe cleaners to clean under the faceplate. That the patient should always be holding on to that faceplate, or the caregiver, whoever's doing the trach care, so it doesn't move around so much. Dressings can be used, but we know not to cut the dressing. So if the patient needs extra 4x4s, they should not be getting the kind that they have to cut themselves because of the lint that comes off those, and that would obviously cause problems to the tracheostomy. And then the trach tube holders would be replaced as needed. So we talked a lot early on about how important it was in securing the tracheostomy tube, because we can run into problems as far as complications, late complications. So we want to make sure that we, first of all, secure it to prevent decannulation. But we also want to make sure we're minimizing the friction and pressure on that trachea and airway. So we know, and I know whenever I was starting in school and early on in my career, we used 12 tape. Well, twill tape was very difficult, first of all, to get onto the patient, especially for those patients that had a very large neck circumference. So it was very hard as a respiratory therapist to do it. So you can imagine trying to teach that to caregivers. So whenever the Velcro holders came out, they are so much easier to put on and so much easier for patients to be able to put them onto the neck plate and get them around their neck easily. They're wider, so they distribute the pressure. I'm sure all of you can relate if you've ever used the twill tape. The twill tape is if you had a large neck and it got into the folds of the neck, then you ended up with severe irritation in that area. So this really limits that irritation. It's very flexible, and again, they can be replaced daily if needed. So the tube holders really should be selected to fit the appropriate patient population. There are ones that are for adults, and you can see they're a little bit wider. You also have ones for the little ones with little stars and designs on them. So you want to make sure that you're getting the appropriate patient population for the appropriate trach tube holder. The high BMI patients with multiple skin folds and shorter necks, they're the ones, like I just had mentioned, are at risk for the pressure injury from the tube ties. So wider and longer holders can fit the necks up to 28 inches, and again, the pediatric sizes are available for that population. How often should we change a tracheostomy tube? This is always the million-dollar question. Frequency will really vary by physicians and institutions. And again, when I was doing research for this, it's really hard to find what best practice is. If you look at the ATS website or the manufacturer, tracheostomy tube manufacturers, they will recommend 30 days. But I don't know about everyone out there, but I don't see that a lot. I see it much longer than that. But again, it varies by the physician and the institutions. The initial change really should be done in the acute care setting with monitoring. Because remember, that trach track is not formed yet, and we run into the problem with maybe not being able to get that back in. So we really don't want that to happen when we're in the home care site with very little support. So what are some of the reasons for the changes? Well, we want to minimize the risk of the tissue formation around the tube. I've seen some really horror stories of this where the tissue has actually formed the whole way around the end of the tube, and when the tube was changed, there was severe bleeding. So again, so important to stress the importance of changing them and making sure that this is happening within our facilities and within our hospitals prior to discharge. And again, this goes back to when these patients do go back into the hospital for whatever reason, or if it's a new trach, we just need to make sure we're part of that discharge team. And I know I sound like a broken record, but in order to understand this, so if the patient had not had a trach change for quite a while and they go back into the hospital, this is a perfect time for us to say, hey, patient hasn't had a trach change for quite a while. Any chance, when the patient's in there, we can get the tube changed. So home health agencies will change the tubes, and there are some, there may be some HME companies out there that do change tubes for patients, but usually patients, I know in the pediatric population, a lot of times the parents are all the time, actually, most of the time, they're the ones that are doing the trach changes and tube changes. Adults can be a little bit more difficult change just because of some different things that occur in the home. So now let's talk about humidification and oxygenation. So early on, in one of the first slides, I said one of the problems with bypassing the upper airway is we are now bypassing our normal humidification, heating process of the air that we breathe. So we have to make sure that when the air or the oxygen or whatever we're giving that patient, they're breathing, that we are giving them enough humidity that will prevent mucus plugging and mucus of the airway. So if they require oxygen, we have some modification we need to do in the home. In the hospital, it's easy. We attach a flow meter to the wall oxygen. We put it on a nebulizer and turn it up to 10 or 15 liters per minute and dial in the percentage. The piped in oxygen, unlimited supply, don't need to worry about it. We have heated humidification available as well in the hospital. We have high flow oxygen systems that are heated and have, the ability to provide high flow and moisture to patients. In the home, we have no piped in oxygen. It's difficult to achieve levels higher than 45%, and heated humidification is typically not used. There isn't really a good source out there that's reimbursable at this time to provide heat to those patients in the home as far as their humidification. So this is just a slide to really show you how we have to adapt when we get into the home and some ways that we can do that. So here is your hospital setting, your flow meter with your nebulizer attached out to, well, this is an aerosol mask, but an aerosol trach mask. It's connected to a 50 PSI source. We dial in the percentage, and then it is anywhere from 21 to 100%. When we get into the home, we actually need a 50 PSI source, or we need a higher PSI source to run the nebulizer bottle. So we have adapted it to a 50 PSI air compressor, and we have to actually bleed in oxygen to get the percentage that we need. So what we end up having to do is really reverse that air-O2 ratio that we all learned in college and never thought we'd ever use it again. Well, we actually have to use it if we use this method of delivery to the patient without compromising their PIFR. And again, we cannot accept an order in liters per minute versus a percentage. Another option, there are concentrators out there that have a higher PSI output. The New Life Intensity by AirCept is one that I'm aware of. It can be connected to a 10-liter oxygen concentrator, and it does have a 20 PSI outlet. So you are able to attach a nebulizer bottle to it and get higher FiO2 ranges. The only thing is you still, 100%, yes, possibly, but I'm not sure if we're not compromising the peak inspiratory flow rate at that point. There's also, I made a note down here that there are high flow oxygen systems. An example would be the MyAirvo. That's an option, but it's lacking a HCPCS code. So you can bill it under the E1399 code and try to get reimbursement, or it's just not an option. Excuse me, I had to take a little drink there. Okay, so what are some of the supplies we need for humidification and oxygenation? Well, if we don't have the higher PSI concentrator, we need an air compressor. We need oxygen to bleed in if applicable. We need the high volume nebulizers, the large bore corrugated tubing, water trach mask, again, oxygen bleed in, and potentially a Venturi mask for transport. I think I sound like a broken record on this as well. Achievable oxygen levels, 21 to 45%. Physician order must be in percentage and not liters per minute. And the high flow oxygen systems that are available now for home, unfortunately, no reimbursement for those systems. So this is just depicting how we have to reverse our air-O2 ratio. So it's really a recipe. So if we're using a 50 PSI air compressor, we have to make sure we know what that nebulizer bottle is set at, to know what the input of air is versus what the oxygen bleed-in is. So it's so important that our patients understand what the nebulizer bottle is set at, as well as what the concentrator was set at. So, I don't know, there's been many times where we go in and just as a follow-up, for whatever reason, they just got discharged again from the hospital, and we check their system and it's putting out room air when it should be putting out 35%. It's because they didn't follow the recipe. So that recipe should always be posted either on the equipment or close by, so that when they are cleaning the equipment and cleaning the nebulizer bottles, they make sure they change the dial and appropriately, as well as the oxygen concentrator. So we also need to be able to oxygenate the ambulatory tracheostomy patient, because the system that I just went through with you, as well as the high flow systems in the home, are limited as far as ambulation. So we can use a Venturi mask. We don't need a humidifier for these, and usually these are just short term, especially if it's a new trach. They just may, still be getting out a little bit, depending on what their history is and what their disease state is. But what we have to remember is these Venturi adapters do require higher pressures as well to drive that Venturi. And most of our oxygen concentrators out there do not operate at an adequate pressure to drive that device. So now what happens is if it's not adequate to drive the device, the percentage of oxygen actually getting to the patient is less. So this was a study that I found by Pepper et al. And what he did was he evaluated the use of the Venturi adapter attached to the standard home oxygen concentrator. He took 3 models of those Venturi devices and tested them for the accuracy of flow and the FiO2. The result, all of them had a decrease in the FiO2 delivered in all 3 manufacturers when it was attached to an oxygen concentrator. So we have to be careful and know what our limitations are on our equipment. So in cases like this, if you don't have the higher PSI concentrator, then those devices need to be run on a cylinder with a higher PSI output. So how do we add moisture to the system if they're ambulatory? Well, we can add a heat moisture exchanger. This will collect heat and moisture and it adds humidity. So these devices have water-loving material. So this is like a sponge, this is a paper, I think this is a paper as well. And what they do is when a patient is breathing in, they trap what moisture and warmth they can, and then when they breathe in the next time, it adds a little bit more to the air that they're breathing. So they are disposable. They really need to be changed daily, and if there's a lot of secretions, they really shouldn't be used because these will block, and obviously we don't want to do that for our patients. And then low flow oxygen can also be added to these devices if needed. We also have the ability to put on speaking valves. And the speaking valves, we need to have a physician order. This should only be put on medically stable patients, and they really need to be tolerant to the uncuffed tracheostomy tube. They can't have copious secretions because it will block this. So these work via one-way valves. So when the patient breathes in, they open, and whenever they exhale, it'll allow the air to flow up past the larynx and allow some speaking. So again, patients really need to be monitored when you're first putting these on, and make sure that their saturations don't drop, that they don't become in any kind of respiratory distress. So again, they need to be monitored closely. So with all this said, we have to also worry about our reimbursement. And I just want to make a disclaimer here that this does vary by payer and by region. So usually you can get a trach tube every 3 months, 1 to 2 trach care kits per day, 1 to 2 disposable inner cannulas per day, a suction catheter per day, a trach holder per day. But what we also have to remember is if a patient is being followed by a home health agency, the home health agency must supply the trach supplies if it's a Medicare patient. So we just got to keep that in mind that under consolidated billing, it is the responsibility of the home health agency to provide that. Now, they are not responsible for the suction catheters. That is our responsibility, but anything related to that trach, they are responsible for. Okay? So weaning and decannulation, this is really a decision based on the examination by the physician and what was the indication for the tracheostomy. So, you know, if it's a disease state that will only progress, then obviously that isn't a decision that would be made to decannulate. The fenestrated tube may be placed or a tube downsized. So if they were on a 6, maybe they'll put them on a 4 and see how they do and wean them that way off of the tracheostomy. They may cap the tracheostomy tube at times at just increased intervals. And again, this will all vary based on the physician and the physician's practice. And then, of course, monitoring breathing and secretions throughout. So how do we know what the readiness is of decannulation? Well, have the indications for the tracheostomy been resolved? So we want to make sure, again, if it is a progressive disease, maybe a neuromuscular disease or whatever the scenario is, if it's progressive, we want to make sure that those patients aren't candidates. So, but all other patients, if those indications have been resolved, for the example I used earlier with the gentleman that had the infected tooth, obviously once the IV antibiotics took place and the swelling went down, then his tube would be able to be resolved. Is the patient tolerating the trach being capped without stridor? So how are they doing with it being capped? Are they having difficulty? Is there respiratory distress? Has a laryngoscopy, I can't even talk, and my mouth's starting to dry up on me. Has a laryngoscopy been performed to confirm patency? So we want to make sure that the physician has looked down into the airway to make sure, do we have a patent airway? And I know this doesn't always happen, but this is some information that I had found from Chung and all, that these are some of the recommendations that they had in determining the readiness of the decannulation. Does the patient have an adequate level of consciousness and laryngopharyngeal function? So are they alert? Or have they had a stroke and we have no consciousness there? Are they able to maintain their airway? Those are things that we want to look at. Does the patient have an effective cough while the tracheostomy is capped? So it's obviously, if the patient is not able to generate an effective cough, they're going to have difficulty removing those secretions once the tracheostomy is out. Has the amount of secretions and the frequency of suction been taken into consideration? So if you have a patient who is suctioning every 2, 3, 4 hours, well, we might want to consider, is it time or should we wait? Or is there an infection going on at this point and we need to delay the decannulation? So again, we really need to take a look at what is the readiness of the patient, especially if the patient is in the home, because if they go into the facility for whatever reason to have the tracheostomy be removed, then when they get into the home, we want to make sure they're stable and so that we can care for that patient and keep them into the home. So, but we still have lots of challenges that we face as HME providers. Well, number one, obviously, is the home environment. We have, electricity issues on many areas. We have clutter, we have animals, and so on. And what is, the safety infection control, because we're not in there all the time. We can be in there once, and, we're the eyes and the ears of the physician, but what happens in 2 months, 3 months, 6 months? And I always like to use the example is we had a patient who was doing well at home and then was being admitted to the hospital about every 30 days prior to the 30-day mark for infection. So they called it, the physician asked us to go into the home and just check the equipment because they thought maybe it was the equipment that was the issue. Well, when we went into the home, it was actually, the problem is the oxygen, high humidification system was in the home, and the gentleman just recently got a bird. And the bird was in a cage above the oxygen equipment. And you can imagine with a bird above the oxygen equipment and all the droppings, that's what was causing the gentleman to be admitted for infections. So again, those are some of the challenges because we're not always there. We don't see what has happened from the time we were there before. And with, the limited reimbursement that we continue to face, our visits to the home are very infrequent. So the patient caregiver and understanding. So again, we got to be able to determine how well the patient and the caregiver can understand this. What is their cognitive level? Can they hear us? Can they see? These are things, if we can address these on the front end within the hospital system or the skilled nursing facilities, it would help us once the patient transitioned in the home. But, sometimes these questions need to be addressed, and sometimes we don't think of this until they get into the home and we have these problems. The reimbursement. So, we have limited quantities that we're able to give patients, and sometimes the cost really exceeds the reimbursement, especially the specialty trachs. You know, some of those trachs can cost 3 times what we actually get reimbursed, and that becomes very difficult to providing care in the HME world. So that's some of our challenges, and I'm sure most of us could agree on this call, as well as technology. You know, we know there's high flow oxygen devices out there that provide heat and humidity, that are quiet, they're not loud, but unfortunately, we are not able to provide them because there's no HCPCS code at this point. And then, of course, our other challenge is follow-up. So there's no coverage for our RT services in the home. So how do you make sure that these patients are safe in the home? And again, it goes back to that continuity of care from the hospital or whatever the health system is, or skilled nursing facility, to make sure that we can catch everything on the front end. And if there are issues, if we have a continuity of care, then they would reach out to us to say, hey, just like I used for the example of the physician, hey, can you go into the home and take a look at this patient? Okay, so we really want to have those relationships with our referrals and our physicians, so that if need be, we got to remember, you know, the patient is the center of what we do, and the patient is who we're trying to make sure gets into their home in a safe transition. So with that said, I think I'm right on the hour. If anybody has any questions.
Kim, you did a great job. I'll let you take a drink.
I hear my mouth was starting to dry. Sorry about that.
No, that's great. I love the story about the bird as well. So I was in here going, oh my gosh. So we did have some questions that have come in to the question queue. So I'm going to just go ahead and start at the top. So the first question is, should we be concerned about skin burns that happen due to peroxide use? Is there a certain percentage of peroxide you recommend?
Yeah, and that's a great question, and I did look that up, and there can, so if you use straight peroxide, you can run the risk of having skin burns, and the one resource that I read said that if that persists, you could use standard saline or a very diluted portion of the peroxide, so like a 1-to-10 ratio, just enough that you are clearing that if the patient is irritated by the 100%.
Okay, great. Next question. It's kind of a comment, but maybe you can add to it. So someone said, I'm sure regionally orders are different, but wanting to know if others use a pat blower and Passover humidifier. Do you have any comments on that?
You know what, I have seen that used, but I know in our area I have not used that. We have not had any. I think I probably have seen that used in pediatrics years ago, but I typically don't see that in the adult. That doesn't say it's not being used, because I am on some websites and feeds, and I've seen people post things to that effect. So I'm not saying it wouldn't work. It's amazing, you know, RTs are famous for adapting. And whatever we can adapt to achieve the end results is what we do. So if you're getting your flow and you're getting your percentage, I don't see any reason why that wouldn't work.
Okay, great. Another question came in. How are you asking prescription for an oxygen concentrator? I'm sorry, for an oxygen percentage to a trach humidity system with a 10 liters per minute concentrator. We can't guarantee a percentage with a concentrator on a liter flow. I'm not sure if I'm saying that correctly. We do not put or use inline analyzers with a concentrator in the home. I hope I said that correctly. Did that make sense?
Sort of. I think I'll take a stab at this one.
Okay.
So I might have. So I guess the point I was trying to make is we need a percentage, and with a 10-liter concentrator, of course, you're not going to put it in line. But because it's high volume, high humidity, utilizing a high volume nebulizer, then you have to know what the percentage of oxygen is, because it's a high flow system. So is it 45%? Is it 50%? And you may only use 5 liters per minute of oxygen bled into a nebulizer bottle that's connected to air at, with a bottle set at 60%. I'm just pulling these numbers out. and that would give you the percentage of 45%. Now, if you use one of the higher PSI outlet concentrators and you put the nebulizer bottle on it and you set it at 45% and you run your flow at 10, then you're pretty much guaranteed your output is 45%. So I think still standard practice is still to analyze it once to make sure it's analyzing appropriately on the initial setup, and then you know, hopefully if you have to go back into the home for whatever reason to change it, that's, I know, when we analyze it. So we don't run an analyzer continuously either through a concentrator. I hope that answered whoever's question.
And I think there was a follow-up to that. They said you can only order a percentage of humidity, not a percentage of oxygen. Oxygen is only ordered per liter per minute.
Well, actually, I'm not sure I'm following that, because whenever you look at oxygen therapy, it can be ordered in low flow oxygen, which would be like a nasal cannula, which is 1, 2, 3, 4, 5, whatever. If a patient needs high flow oxygen where we're providing their entire peak inspiratory flow rate, then we need to make sure that everything we give them is a specific percentage. So that's where you need to do the combination of using air and adding in oxygen to get a certain prescribed percentage. It almost works like the Venturi mask, where you have a set Venturi set at, say, 50% with a Venturi adapter running off of a concentrate or running off of an E-cylinder at whatever recommended flow rate it is. It automatically builds that mixture. So we have to do the same thing when we're working with high flow oxygen patients and trach patients to provide that. So I hope that answers their question. I would be happy if they needed to contact me directly, I don't have a problem with that either.
Sure, that's
I'm not
totally
sure
fine.
I answered that appropriately.
And we can follow up that. We can certainly do that.
Okay.
So switching gears, there's another question. Do you have any guidelines on usage time of 50 psi nebulizer without oxygen to provide adequate humidification to the trach patient? Physician's orders never say.
Well, that's just a great question, because that goes back to my one slide when I said there's no standards out there, and we all make our own standards. And there's really no best practice out there as far as clinical practice guidelines on that. I know that we typically, this is what we use, and I'm not saying it's right, and I'm sure everybody out there probably has something different, but we tell them to dispose of it at a minimum of monthly with a regimen cleaning protocol that we have them do. And if they need to replace it sooner than that, we tell them to replace it. And it really depends on the environment. So if we know if it's a questionable environment, we may have them change it more regularly, but routinely we will have them throw them out monthly.
Okay, thank you. There was a comment that they use a procedure code E1372 to bill for the APN heater. They said not all insurance payers will pay, but a few do. I think that was just more of a comment, so thank you. There also is another question. What is the liter flow for an ambu bag that is in the home setting using an E-cylinder?
Well, I think that varies. I think if it depends, because we get ambu bag orders that really aren't even prescribed to be used with oxygen. It's just to hyperinflate the airway. I think it would depend on your physician on what they would recommend, because I'm not sure I'm comfortable giving you an answer, because I'm not sure I would be right. I know in our homes, we have some that we don't even run oxygen to, it just depends. And then we have others where they tell us to put 6 liters into the ambu bag prior to, suctioning patients. So I think it's just going to vary by physician.
Okay, perfect. Next question, how do you connect the oxygen into the air compressor? Up by the trach collar?
We usually bleed it in back at the nebulizer, just because a lot of times if you're bleeding it up at the mask, you run the risk of it becoming disconnected. So our protocol states that it'll be bled in back at the nebulizer.
Okay, thank you. A couple more questions. You're doing great. I feel like you're on trial here. Next question. What is the required detail written order look like for an HME provider for trach order and supplies? Is trach services bundled or items charged individually? What is the supply replenishment schedule?
It varies by payer. I know in our area, and I mean, we do get supplies for like suction tubing, or I'm sorry, suction catheters are typically one a day. We typically can bill for a trach every 3 months. We typically can bill for the trach tube holders one a day. I'm trying to think what I missed there. The trach care kits, usually 1 to 2 a day. And then the disposable inner cannulas, usually 1 or 2 a day. So that's what we see in this region, and I know it varies. It's all over the place. As far as a trach order looks like, we don't get a trach order that specifies the exact quantity of supplies. We just get what the order is, what their needs are, and then we give them supplies based on their insurance. And then if they're, you always get those rare patients where you have to go outside the system for whatever reason. And I know we have one now where the patient needs to be suctioned much more frequently, has high risk for infection, and we were actually able to go back to the insurance company. It wasn't Medicare, it was a private payer, but we were able to go back and get a different reimbursement rate. So again, we don't get a prescription that is specific to the quantities. We actually get a prescription that's specific to the actual supplies that are needed.
Okay, great. We're whittling them down. We're almost done. Another question that came in. So I think this is a scenario. So patient discharged home with speaking valve and vent HS. We want to utilize a nasal cannula during the day while off the vent, correct?
Yes, but I mean, you have to get a prescription for that. So if the patient is off the vent and using the speaking valve, then you would need, if you need to put oxygen on them, you definitely want to get a prescription for that from the physician. Even if it's you may even get a prescription to, titrate them, make sure their saturations stay above a certain level, but you would definitely want to get a prescription for that.
Perfect. Next question: What is used more in homes, disposable or non-disposable canisters?
Disposable, in this area anyway.
Okay, that is all the questions that we had, believe it or not, that is entered into the question queue. So I think that's it. Kim, you did a wonderful job as normal. You're a pro now. We do want to just thank you for your time.
Oh, thank you so much. Thank you, everybody. I hope you learned something.
All right. So much, Kim, and with that, everyone have a great rest of the week, and we'll go ahead and end the webinar. Thank you so much, Kim.
Okay, thank you.
Right.
Bye-bye.
Bye-bye.